Thank you for joining us this evening. I and the North Western Melbourne Primary Health Network would like to acknowledge that wherever we are today, we're meeting on the lands of the traditional lands of the First Nations people and pay our respects to them past, present and emerging. For me, that's the Wurundjeri Woi-wurrung people, the Wurrung people and the Wutharong people. Thank you for joining us this evening in what I think will be a really interesting evening with the Minister. My name is Ines Rio. I'm the Chair of the North Western Melbourne Primary Health Network. I'm also a GP and I work at North Richmond Community Health. And I've also been on the senior medical staff at the Royal Women's Hospital for over 20 years, where I'm a GP obstetrician and I lead the GP liaison unit and the shared maternity care unit. So just a little housekeeping to start off with. This event is being recorded and will be available for viewing after the event. Thank you to all of those who have submitted questions, and thank you in advance for those who will submit questions via the chat during the forum. Our preference is for people to ask their own question. So if you're happy to do so in the question, if you could add on camera to your question. If you prefer that I ask them, please include ask by the host. If you could also include your name and role, and that will be publicly available to all, that would be helpful, such as Ines Rio, GP, Richmond. Unfortunately, we're unlikely to get to the many questions this evening. We thank you in advance for providing them. And if you'd like to engage further with the PHN about your topic of interest, we'd be delighted if you emailed us via info@nwmphn.org.au. Thank you again for joining us. It's now my pleasure to introduce our special guest for this evening, the Hon Ged Kearney MP, Assistant Minister for Health and Aged Care, and member for Cooper, which is an electorate within the North Western Melbourne Primary Health Network catchment. Assistant Minister Kearney qualified as a registered nurse and has a Bachelor in Education and worked as a nurse for many years and a nurse educator before entering politics. I'm very aware, as many of you are, of her keen interest and strong advocacy in women's health over many years. Thank you. She's been instrumental in preparing the recent federal budget and in particular the Women's Budget Statement. And we're honoured that she's taken an hour out of an extremely busy schedule to join us this evening for a discussion on women's health and the budget. So welcome, Assistant Minister Kearney, and thank you once again. Over to you.
Oh, thank you, Ines. That was such a lovely introduction. Thank you. And can I just, first of all, say a big thank you to you. We have met a couple of times and I always find your advice and your help incredibly supportive, and it's great to know that you're there actually in many different ways. You pop up all over the place, so you're incredibly busy yourself, and thank you for all the great work that you do. And well, I too, I would like to acknowledge the traditional owners of the land on which we're gathered and pay my respects to elders past, present and emerging. I myself am also on Wurundjeri country, here in my office of Cooper, which of course is named after the wonderful William Cooper, a great Aboriginal activist. And I'm very proud to be the first member of Cooper, because of course it was named Batman before we had a little campaign to change its name. And I'm also very proud that the Labor Party will be implementing the Uluru Statement from the Heart in full. And I ask you all to be prepared to have conversations and to talk about the voice, which of course will be coming to a referendum near you very soon, probably next year, something that's a very important part of the Uluru Statement. So first of all, what a wonderful idea to put on the forum. It's fantastic for me to get out, albeit virtually, and meet and greet. I know there's a lot of health professionals and a lot of health consumers on the line, and to be able to have that really good, intimate talk, albeit virtual, with you all. So I'm not going to talk for very long, but I'd like to thank the North Western Melbourne PHN for having me, for you, Dr. Rio, for organising the chat, and everybody up there who's worked so hard behind the scenes to get this together. Thank you very much. Primary healthcare networks are doing amazing work on the ground, and I know how hard you all work, and really I've just realised in this role that you're all things to all people in many ways. Like we have a problem, we say, oh, let's get the PHN to fix that. You know, it just seems to be that they have to really do so much amazing stuff to keep the system ticking. So thank you very much for all the work that all the PHNs do, and to everybody here online tonight from other PHNs. Your work is greatly appreciated. It is a big turnout tonight, I understand. There are lots of people. Makes me a little bit nervous, but nevertheless, it is lovely to have you all on the line. So thank you very much for coming on. Now, the main theme, I understand, is talking about women's health, as you said, and it's something that I am so incredibly passionate about. And as a woman who turns 60 next year, I've lived a long life as a woman with various health issues and have worked in the health system, as you said. I was a nurse for many, many years. And look, there's just so much to talk about. It's hard to know where to begin, but I have some wonderful people, some of whom are online tonight, including yourself, Ines, who are going to help me work through the myriad of problems and issues that I think women face in our health system. Some of you may know, as you mentioned, I was a nurse for sure, worked up at the Austin Hospital for most of my life, my working life, nursing working life. Then after that, I headed up the Australian Nursing and Midwifery Federation. I did that at a federal level, not a state level where much of the industrial work is done, but at a federal level where I really delved headfirst into the area of health policy. And that was really the role of the federal ANF, was to make sure that federal health policy was firmly on the agenda of every government. So I then worked at the Australian Council of Trade Unions. I was president there for nearly 10 years. An incredibly a great privilege it was, in fact, to be able to represent working people in this country. And of course, I dealt a lot with what we would call the social wage at the ACTU, where things like access to healthcare were incredibly important to working people. So we fought very hard for Medicare, to keep Medicare in safe hands, and also to have universal access to healthcare, something I know Australians are incredibly passionate about and proud of. I've just gone through all that. Some poor person wrote me a very lovely speech to give you tonight. Now I'm just ad-libbing and not taking any notice of what they wrote for me. Look, I have to say that I'm proud, very proud of my advocacy in health, and I've met some wonderful people on the way. And one thing I've learned, I think, in those roles is that you can't do everything by yourself. One lovely man I was talking to today said, you can't clap with one hand, Ged. And I'm really looking forward to working with all of you, to working with the PHNs and everybody who's passionate as I am about the health system, to making change for good and reform that actually sends us in the right direction. We started off well, I think, in the Labor Party, and as we have 5 ministers sworn into the healthcare portfolio. We have Annika Wells, who's going to be heading up aged care. She's already working really hard to address the crisis in aged care and implementing the recommendations of the Royal Commission. And of course, aged care is an area that predominantly employs women. And I'm extremely interested in the care economy, because not only do women rely on the care economy to participate in the workforce and for all sorts of reasons, but they predominantly work in the care economy. And I was incredibly proud when we said we would support, as part of our measures in the aged care crisis, a pay rise for all aged care workers. So it's going to be incredibly important. Melanie McCarthy is the Assistant Minister for Indigenous Australians and Indigenous Health. And I know that she will be focusing on First Nations health. She was so proud to tell me about all the extra dialysis chairs that are going to be funded in Central Australia. But of course, wouldn't it be wonderful if we could deal with the issue of renal failure as well in a preventative manner. So she'll be focusing on that as well, and also our efforts in closing the gap targets. Emma McBride is the Assistant Minister for Rural and Regional Healthcare for Mental Health and Suicide Prevention, and she'll have a big focus on delivering equitable outcomes for Australians who don't live in the big cities. And of course, massive issue of mental health in this country, which affects all communities. Particularly since COVID, I think it's been really highlighted. There's Mark, of course, who heads up the team, and Mark Butler as the Minister, and he's really tackling the big reforms, leading the work on workforce. I've got to say, as I've talked to you, Ines, about like workforce. Yeah. It just underpins everything. And if we don't get that right, then we're going to fail on all other measures. He's also heading up the Strengthening Medicare Task Force. He's leading the way on primary healthcare reform. There's one thing I know about Mark is that he's really keen on shifting the focus of our health system into primary and preventative healthcare. And he worked, you will recall, he worked as Nicola Roxon's assistant minister when Nicola was health minister, and she did some amazing work in this space. So I know Mark is very keen to do that as well. He's also working on a few other things about, the tobacco. He's very interested in tobacco and the issue of vaping and HIV, a few other big public health issues that he's interested in. Certainly. And then there's me. Sorry, Ines, sorry.
I was saying that certainly some of the issues that you've raised are the sorts of thematic analysis that's coming through, residential aged care, access and equity, the issue of actually addressing things at a preventative health level, and also that rebalancing of the system towards, general practice, primary care and community care rather than that acute tertiary end. So it's very heartening to hear all of that activity that's actually happening in that policy development.
Yep, definitely. That's going to be the focus of our work. And then for me, as the Assistant Minister, I'm kind of a bit of a, across all of these things, but areas that are particularly, I think they're a natural fit for me and things that I'm really keen to use my experience in is, of course, the area of women's health. Very passionate about that, as I've said tonight, and happy to talk to everybody about that, where I'm heading. I'm very interested in particularly looking at the bias in the health system that is based on sexual differences. So I think people would agree that there is a gender bias in the health system, that women aren't necessarily best served by our health system, and there are a lot of areas that we could improve. And I'm sure that we're going to talk about a lot of those tonight. If you look across the whole system, this is one thing that I'm really keen on looking at is, for example, research. We know a tiny amount of NHMRC grants actually go to women researchers. We fixed that recently with a fabulous announcement that NHMRC have to give 50% of their funding to women researchers, which I think would be great because often women research women's health issues, and this may just raise that profile of women's health issues up the priority list. Who knows?
And the other thing I'd say is, most NHMR or very little NHMRC grants actually go to primary care and translational research.
Yeah.
In the UK, they've sequestrated at least 5%, and that would be a massive increase for us. And if you think about the fact that, again, that sort of gendered workforce within general practice and primary care is mainly in the community sector. And so those sort of women's health issues, those issues of access and welfare, the social determinants of health, that's where it lives within our healthcare sector largely, I think.
And I know we're digressing a little bit, Ines, but I'm really interested when we've been looking at workforce for rural and remote areas, being able to offer research that is based in those areas in general practice, and being maybe able to fund those that sort of research, even sort of action research, if we can't get, university-based research, I think would be really helpful to retention in those areas. So giving doctors, giving nurses, all sorts of health practitioners access to be able to do research while working in rural and remote areas, I think would be fantastic. And I've been having some really good conversations with the Rural and Regional Health Commissioner. Is it Ruth? Her name has just leapt out of my head, which isn't a good sign, is it? It's late in the day. But, there are lots of areas, I think, and some of you will have seen the research about, things like hip prostheses that are designed for men and cut down for women. So women have a far greater rejection rate than men. Who'd have thunk women's pelvises were a different shape? Who would have thought? Who would have thunk that, You know, the issue of women being over-medicated because they're not properly represented in clinical drug trials. I'm sure you're aware of all of this. And then, of course, there's things like women not being believed when they say they're in pain, which is, I think, is a huge issue, or given appropriate treatments when they complain of pain. I think there's a twice as likely after 6 months to die of a heart attack than men. There's lots of areas I think we really need to focus on, not to mention big areas like menopause, period pain. Grin and bear it. Yeah. It's just a woman's lot. It's just a woman's lot.
Some questions, shall I?
Yeah, we'll have some questions. I could bang on about this, but yes, we probably should get to questions.
No, I think that we'll incorporate lots of the things that you've talked about within the questions, actually. So I might start off with something that's close to my heart, and I know has been raised by many people in the community, many GPs, and actually many people, which is the actual, you know, since the US Supreme Court actually overruled Roe versus Wade, there's been a lot of concern about the fact that, you know, reproductive rights aren't enshrined in Australian law. And, you know, could we potentially actually have the same sort of issue being a political football in Australia? And I suppose I wondered whether you were concerned about that, and what can the government do? What can we all do to ensure that that doesn't happen?
Well, you're quite right. Being a federation, and as we have different legal frameworks in each state, that of course terminations in particular are a state, pretty much a state issue, particularly surgical ones, access to surgical abortions. And there are different laws in each state. Some are better than others. Some, like New South Wales, only just made abortion legal in very recent times, as you know. And it really is another area that has really highlighted the fact that we are a federation, and the role of the federal government perhaps in harmonising a lot of that legislation, particularly around access. I think we are lucky in Victoria at the moment that it has been a bipartisan position. We have the National Women's Health Strategy that says access to contraception and reproductive health care, including terminations and abortion, is actually a key target and a key outcome of that. So I think in some ways we are a little bit removed from what happened we're luckier than what happened in the States with Roe v. Wade. It hasn't quite become the political football in Australia that it is in America. But I think, you know, looking at some other areas that have been made political footballs, there's potential for it to happen. You know, look at the Sex Discrimination Act. That was awful situation just before the election. So there's a lot of work to do, I think, federally, to make sure that we make access to these services readily available, accessible, affordable, and there's a lot of work to be done. This is an area that I am very, very keen on pursuing, and I'd be keen to hear some views of the people on this forum, to hear what they think we need to do. There are basically reproductive healthcare deserts in Australia where it's almost impossible to get care. Access to medical terminations should be much easier than it is, and I'm definitely looking at that. It's very difficult to get any national data on where surgical terminations are performed and where women can go to get them, so we can't even really set up a national database. Surgical termination data, as you know, is wrapped up in miscarriage data or normal D&C for other reasons data, because it's similar, I believe. Yes, you're nodding your head, and with your RANZCOG hat on, you would know that. So it's very difficult to get data, and I think, you know, it's an area that I think we need to do a lot of work very quickly. It's of course all wrapped up in women's access to long-active removable contraceptives, LARCs. The answer's complex. I'm finding, and I don't think it's just, you know, very few, and I'm interested in your views and your people's views on very few doctors trained to do abortions, very few GPs, you know, are available to insert LARCs. There's a whole question of, are they too painful for young women at the moment in the media? There's a lot of talk about LARCs insertions being painful, and again, women's pain not being taken serious. So that's a real barrier to young women having them done. They get frightened. So there's all sorts of policy areas here that we're going to have to do a lot of work on, I think.
I think so, but I think that there are solutions through, and I think that that idea about the, you know, what's the federal remit over ensuring that, you know, there is legislation that's countrywide that protects issues, protects this and keeps it as a health and human right and a reproductive right. And then there's the question about training and support. And, you know, there's about 1 in every 10 GPs that provide medical termination of pregnancy, but you don't need every GP to be able to do it, but you need systems that are linked. And you need that sort of, you need the training to actually insert IUDs. It's really quite hard to get training. So you need that collaboration between hospital settings and that role and remit where they're expected to actually train GPs and also nurse practitioners, etc., to insert LARCs. So I think
agreed.
That's the way to go. So you know, with a shared vision and understanding, I think, and roles and responsibilities, it's absolutely doable. But you actually touched on a question that was being asked by lots of people, which was that accessibility to affordable, long-active, reversible contraception and termination of pregnancy. So it's great to hear that it's front of mind.
Absolutely.
And I'd like to be part of that sort of policy solution moving forward, informed by the sorts of people in the PHN that have so much on the ground understanding of what's happening and such a systems understanding of what's happening too.
And I think, you know, you say 1 in 10 GPs, but you know, if you go to regional areas, it's much worse. And I had a woman talk to me the other day. She said, Jed, I'm a very wealthy woman. I went to 3 GPs to get a LARC. I couldn't get one. I ended up going to the public hospital and taking up public patient time when she said I was prepared to pay and do it privately. And but you know, that was in Sydney. So imagine how it is if you live in Dubbo or Kimba or somewhere like that. So access to reproductive health care is a major issue of mine and a high priority, and I will be working very closely with the sector on it.
Thank you. And the cost difference in actually insertion in a public hospital versus insertion in the community is amazing as well. But I'd like to just hand over to Kate Grinley, who's the Director of Care Integration at Your Community Health, to ask her question about sexual health and reproductive services. Over to you.
Hello, Kate.
Hi, Jed. Lovely to see you. You started answering my question just as I'd posted it, so thank you. But yeah, just wanted to reiterate that, you know, one of those access deserts is in the north of Melbourne, and where we serve the community of Darebin and surrounds, and we can't run a sexual and reproductive health service using MBS funding without running at a loss, particularly for the groups of people we're trying to serve in terms of, you know, not just people who are not Medicare eligible, but for people who have complex lives and can't produce a Medicare card. And that has knock-on impacts for doctors prepared to do the training and all of that sort of stuff. So I'm not expecting you to throw money at us right now, Jed, but I'd love to know what you're considering at a federal level, because there's lots of people on this call who desperately want to provide these services. It's just not currently possible under the funding that's available.
Because they don't have Medicare cards, Kate? Is that what you're saying?
Or people who are not Medicare eligible, but also people who have complex lives who might be Medicare eligible, but they're, you know, getting it replaced or et cetera, et cetera. You know, there's some ongoing complexities there as well because of the nature we serve in community health.
Okay, just on, and with respect to LARCs, I have some big plans for LARCs, which I can't reveal on today, unfortunately. But I think, you know, there's a lot we can do to help make that more affordable and more accessible. And, you know, part of that answer, of course, is the workforce. Well, funding community services like yours, properly funding community services, I think, is a vital part of a robust and accessible and affordable primary healthcare system. But also utilising the workforce that we have. I know, Ines, you mentioned nurse practitioners. Nurse practitioners are, I know there are some already that can do that service, particularly in nurse-led clinics around the country. Why can't they do that in the country, in the rural and regional areas as well? Midwives, I know midwives are allowed to put implant on, for example, in women up until 7 weeks postpartum, post-birth, but they can't do it beyond that. So I think there are things we can work. We can have a look at about how we can make things much more accessible with respect to ARCs. And I have a dream that we will have a women's health clinic in every PHN, Ness. And that these women's health clinics, or 2 or 3 in every PHN, will do all sorts of care for women, from fertility care, maternity care, all sorts of reproductive health care, right through to terminations and contraceptive care, and maybe pelvic pain care. I think it would be wonderful if we could have that in all the PHNs. We are, of course, at the moment working with the PHNs to establish our endometriosis clinics, which will be endometriosis and pelvic pain clinics. So they will be slightly broader than endometriosis. But yes, it would be wonderful if we could have a focus on women's health, where these things are properly funded, properly staffed, with a skilled workforce, working to their full scope. It would be wonderful.
Thank you. Thanks for your question, Kate. And one of the issues, I think, with all of those in endometriosis clinics, pelvic pain clinics, and sort of separate women's clinics, is actually how they enhance the care that's actually provided by traditional general practice, and actually do it in a way that's integrated rather than fragmented. Yeah. Also, that has to be given some thought, I think, in the development of them.
And I think that's where the PHNs come in, so that
that we complement people's care
with the health.
That's right, increase the capacity of general. We've got a question here by Karen Hoffman, practice manager at North Coburg, who'd like me to read it, which is: several practice managers had actually asked this in various formats, which is actually about the workforce shortages in general practice. So Karen's question is: we've had 4 GPs retire in 2 years. While there's a lot of help to address rural doctor shortages, and I think that there's recognition of rural doctor shortages, what's being done to alleviate the shortage of GPs in metropolitan regions?
Yeah, and this is the question. This is workforce, and I can guarantee that this takes up probably the biggest percentage of our time when we, as the various ministers, come together to talk about this. The pipeline for GPs, I think, is something that we're really trying to work on, to work with the Royal College of General Practitioners to make sure that it is a pathway of preferred choice. And there's a lot of programs happening at the moment with the college and with the various universities and with the profession broadly, to try to encourage people through that. I think, I'm particularly interested in looking at how we can encourage, and Ines, I'd be interested in your views on this, because I know you're a GP obstetrician, is that right? Yeah. So I think specialist GPs, those pathways are so important, and I think they are really going to help if we can encourage people to do that, even in the cities. I know we encourage it in the rural areas, but if we can encourage it right across the board, I think that would go a long way to sort of making that GP pathway. Do you think much more sort of?
I think that some of the things that Minister Butler said, that he found it a terrifying statistic that only 15% of graduates actually want to become GP.
Oh,
and that's down.
Absolutely. This is a pipeline issue. We're not quite sure how to.
And it was actually,
we're working on it.
Yeah, I know, but it was really heartening to actually hear him say it was one of the single most terrifying statistics that he'd heard.
Absolutely.
And I think that some of the things that we've already talked about, the issue of developing a career pathway for general practices in forward, that might incorporate special interests, that might incorporate research, policy development, education. There's a way, I think, of crafting the work in general practice that makes it more of a lifelong balanced career. But the problem at the moment is it's almost hitting that sort of death spiral, because the less people you have choosing to do it, the less attractive it becomes. So I think that there needs to be very positive investment into general practice, which I understand is being.
I also think that part of the answer is if you talk to general practitioners who are, you know, very overworked, tired, you know, their own mental health care is probably in need of some attention, and particularly in rural areas, again, rural and remote areas. I think models of care that incorporate practice nurses,
Yes.
You know, nurse practitioners, midwives, allied health, so that if we can actually get models of care that are truly multidisciplinary, that can relieve some of the pressures, I guess, on our GPs, I think that, you know, we would be going a long way to providing a better healthcare system. And talking to a lot of general practitioners on the ground, you know, they say to me, "Oh, I couldn't do it without my practice nurse."
Oh, absolutely.
You know, I couldn't do it without the multidisciplinary approach. I'd never get to visit an aged care if it wasn't for my nurse practitioner that, you know, goes into the aged care and delivers that. Or, you know, there's models of care in Tasmania that I learned about recently at a conference where there's you know, whole teams of people just keeping people out of GPs, including nurse practitioners and allied health professionals, taking the pressure off GPs and ED, so doing referral lines along. So you know, there's lots of models of care that we need to be a little bit innovative, I think, when we're looking at healthcare provision.
Lisa Simpkins has asked a question, and she's asked me to read it out, and she's a primary health nurse. And I think this is a really important question. It's general practices are also finding it hard to recruit nurses into primary healthcare settings, with many nurses taking up better paid government roles within vaccination centres and respiratory clinics. And what role can the federal government play to attract nurses to move into and remain in primary healthcare?
Yeah, absolutely. There's again, it's a really big pipeline issue. I've been having lots of conversations with the universities about how we can do better undergraduate placements, for example, in primary healthcare, because you know, I remember working up at the Austin Hospital. Part of my job was to you know, coordinate all the undergraduate nurses' clinical placements in the Austin Hospital, and I've still got a twitch in my right eye from having to do that. But we focus so much on the tertiary clinical placement, and really you might get a week in a GP or a week in, you know, community nursing, or a week in a community health centre as an undergraduate nurse. We really need to boost up that exposure in a big way. Now, that might mean revamping the way universities actually place students. It will mean supporting nurses who have to support students in the primary healthcare sector. But it's all worth it, I think, if we can actually start that pipeline moving. And of course, there's remuneration issues and incentive payments, all sorts of things that roll into that. But I do think it's going to be the answer is a multidisciplinary approach, definitely.
And I was talking to the CEO at APNA last week or the week before. I think it's over 20% of nurses that now work in the community, if you take general practice, but also residential aged care services, you know, not hospital, school-based services, etc. But I don't think that there's any compulsory actual curriculum requirement at all in the university undergraduates. Then there's the issue, as you said, of placement, and also the issue of, you know, that really fairly large gap in remuneration. And even the state government that said, look, you know, we'll actually fund places moving forward, was all about the hospital-based system, not about the community-based system. So I think that there's a lot of thinking to be done and understanding about the value and the importance of nurses in that primary care sort of setting. Absolutely. I've got Sam Reid from Sexual Health Victoria who'd like to ask a question about upskilling nurses and Aboriginal health workers. Over to you, Sam.
Thanks, Ines. Can you hear me? Sorry, I'll just start.
Yes,
I can hear you.
Oh, allow me to start my video. Sorry, I'm on my phone. Let me see if this will work. Oh, sorry, it won't work. I'll just have to talk without my camera. My name's Sam Reid. I work at Sexual Health Victoria as the Manager of Schools and Community, and work in clinical education as well, upskilling nurses and doctors, especially around LARC training and access. And we've actually been providing Implanon NXT insertion and removal training via Zoom to remote and rural communities, especially to GPs and nurses. I was just wondering are there any plans to improve the role of telehealth and digital health in the reproductive and sexual health space, and also more broadly plans to further upskill nurses and GPs, but also the Aboriginal health workforce to provide reproductive and sexual health?
Absolutely. There's lots of individual programs, Sam. For example, we've funded a really fabulous birthing on country programs. We've funded in the last budgets is it the Nowra Hospital, where there's a great Aboriginal birthing program where the Aboriginal health workers and Aboriginal midwives actually have collaborative arrangements with the hospital to deliver babies in the hospital and go with the mums off country into the hospital if need be for those babies to be delivered. Very successful program. So there's lots of sort of individual programs happening. We've recently made sure that art shows have access to publicly funded insurance so that they can employ midwives without no fear, which has been a sticky issue. So there's lots of individual things, but I think overarchingly, which is what you're asking me, and congratulations on the work you're doing. I think it's just amazing and really wonderful. Melanie McCarthy will be working with us to look at how we can actually, from a federal level, have an overarching policy program around improving access or improving actually the health workforce in Aboriginal communities. And I think that's going to be really important. I'd love to have Melanie here to tell me her thoughts and things, but just rest assured that that's certainly one thing that she's looking at, so we can provide primary health care to those communities, to First Nations communities. With respect specifically to LARCs, it's really interesting to hear that you're doing that, and I'd love to hear a bit more. If you've got any information, I'd love you to send it to me about how you're doing that digitally and online. I think that's exactly the sort of things that we'd be looking at. Mm-hmm. And with respect to telehealth, we discovered recently that there's some really important telehealth items that will finish soon. The previous government ended it. They were COVID measures, I think, for reproductive health care, access to medical terminations and getting prescriptions via telehealth. So I'm really hoping that we'd be able to continue that. I didn't realise that the funding cut off actually very soon to that. Just sort of brought to my attention. So I've raised that issue with the Minister just yesterday, actually. So we'll be going back and having a good look at that. But if one thing we've learned from COVID, telehealth is actually incredibly important.
It's not where we need to stop, but it's been an absolutely wonderful tool moving forward. And thank you.
So thanks, Sam.
Sam. I've got a question here about the $26 million to fund the National Network of Perinatal Mental Health and Wellbeing Centres. And I believe there's 20 million to strengthen pregnancy, so that's great. But most mental health preconception care, pregnancy care in the first trimester and postnatal is actually undertaken in general practice and by community midwives as well. So the question is, how do we actually ensure that investment enhances the care and improves the capacity and capability of general practice, rather than fragmenting women and fragmenting care and decreasing access and equity?
That's a very good question. Someone who really doesn't, I don't have the remit over this, but I think it's about collaboration. I think it's about working with the PHNs. It's about working with midwives on the ground who are doing the care. It's about making sure that we feed back up the best way to do this, and of course that's through consultation. I'm just going to look offline here for a minute. Do we have information on the perinatal money? I might need to take, I'm not quite sure how that money is going to be distributed, Ines. I haven't really had line of sight over that, but I'm very happy to take that question on notice, because I absolutely hear what you're saying, that if we do build a national network of perinatal mental health and wellbeing centres, which I think is what the idea of it is, isn't it? That
yes.
We build this network right around the country, that we have to do it, that enhances care. And as you say,
community care.
Yeah, that's right. I think I think the Gidget Foundation, is that right? I think the Gidget Foundation will have an important role to play in setting the centres up. And
I think that would.
I'm pretty sure it's the Gidget Foundation.
I mean, it's really, most of the PHNs, there's 6, as you know, in Victoria, and there's 31 around Australia. Certainly we have expert advisory groups here on, you know, general practice, on drug and alcohol, on mental health. We also have a people bank. We also have a people bank of, you know, about 160 people. So you can get lots of that sort of information and collaborating through us. So I'm just going to go to the next question. Oh, it's also being asked by me, which is from Rachel Whiffen, who's the mental health advocacy lead at the Murdoch Children's Research Centre. And she's basically talking about research has shown that maternal mental health and wellbeing has been impacted by COVID-19.
Yeah.
What measures will the government invest in to improve women's mental health and wellbeing, knowing the significant impact this can also have on children and families?
Yeah,
inevitably,
absolutely.
really.
Yeah, it's been absolutely astounding, really, the impact that the pandemic's had on young children and babies born during the pandemic. My granddaughter was born during the pandemic, and I might have told you this, Ines, but for the first 6 months or 7 months, when we would finally be able to touch her and hold her and be part of her life, she screamed.
Yeah.
Absolutely screamed blue murder every time she saw a stranger come near her, even her own grandmother, which broke my heart. So it took a long time for her to come over that. We've heard kindergarten teachers saying that kids coming into kinder, they're just, it's such a struggle for them, and a lot of them are really, you know, clearly their socialisation skills are very low, and there's been a lot of huge impact because of the pandemic.
You know, the speech, fine motor skills, social
fine motor skills, even gross motor skills, catching a ball is what I'm hearing. They're really struggling with things like that. So I really hope that the money that we were just talking about, is it 26 million to fund these perinatal mental health centres, will, you know, really help women going forward. As to what, you know, supporting young ones now, I think it's really, and mums now, I've been talking a lot about filling that gap between the 1 and the 3-year-old, where mums get quite a bit of support, you know, from maternal and child health nurses up until about 1 year, and then they might start kinder or preschool at 3. But in between, there's a bit of a gap. We're looking at wraparound services in there. We really want to set up integrated and complementing services where there's proper referrals to general practitioners, to child and maternal health nurses, and where we have really effective perinatal mental health screening, which I think that, you know, this funding is really all about. I will take loads of advice from the experts, how we help this generation that is coming through now, like you and I were just talking about. But I think with this funding that we were just discussing, I think we're on the road to being well set up for the future.
And I think women through that. There's sort of primary preventative aspects, there's the secondary preventive, and there's the treatment that goes right through that sort of whole family environment, be that at the mother's level, the parental level, and the child's level. And as you said, it's multidisciplinary. You know, it's a school issue, it's a childcare issue, it's a family issue, it's a healthcare issue. It's complex. That's right. Doable.
It is complex.
I'm just. I might just hand over to Anne Moldaway, who's from the Older Persons Advocacy Network. Okay. I might ask a question about sexual assaults in residential aged care.
Oh, yeah.
Over to you.
Thanks very much, Ines. Thanks very much, Ged, for your commitment to women's health. I'm now working at the Older Persons Advocacy Network, and an estimated 50 sexual assaults occur every week in residential aged care. And I'm interested to know what the incoming government's commitment is to preventing sexual assault of older women.
Look, this has really been raised with me on a number of occasions. It's really a very serious issue. We did enact legislation, I'm sure you know, Anne. We enacted legislation in October that all unlawful sexual contact had to be reported from aged care residential facilities, which I think is, and they had to report it as a priority 1 category, which I think is a great outcome. They have to do that within 24 hours of an assault being reported. And I think the more data we get, I know that you have some good data there, but we suspect that there's a lot more data needed, and so that we can actually get a good grasp of the problem. The commissioner, the commission will actually, the Safety and Commission, the Aged Care Commissioner, will have to review all these incidents within 24 hours and see if there's a high risk of the resident having to be removed from the situation, which is not always easy to uproot someone and remove them. And it's hard to isolate perpetrators in facilities, because we know what aged care facilities are like, and these issues can be very complex. But we are implementing serious penalties for not reporting and not acting on advice to remove a patient from harm. The Royal Commission touched on this, and I think we really need to implement those things. I'm just looking here because I do actually, believe it or not, we have some notes on this. There will be a code of conduct from the 1st of December 2022 for all providers and their staff, and this will require providers to take all reasonable steps to prevent and respond to all forms of violence in the residential aged care setting, and there will be civil penalties that will apply. We're funding OPAN, as you know, with some funding for their elder abuse prevention project, which I'm looking forward to the outcome of that and how you're going to go about that. So it is a very serious issue. We want to take it serious, and we're looking at working with you particularly about how we can best manage it above and beyond the things that we've implemented.
Thank you, Ged, and thank you, Anne, for all your work in that area as well.
Yeah, thank you so much for all your work in that area, Anne. It's a difficult, I know how difficult it is in residential aged care.
It's a very difficult area, and I think at the start of this session, people were talking about women's pain not being recognised, and I think you've got some intersections there for older women, particularly living in residential aged care, and their expressions of pain and their reports of abuse, of not being believed or of being underestimated, of the impact it has on them. Thank you.
That's absolutely, and I think that's why the data is going to be incredibly important. But I'm happy to talk to you about that intersectionality at any time.
So satisfying when it improves and you get it right. You just see those tangible improvements in people's lives so quickly. So
yeah.
Just a question from Elaine Cotter, who's a practice manager at St Albans, asking about osteoporosis. Osteoporosis has emerged as highly prevalent in women aged 50 to 65, yet we don't have a public health service in our area to cater for this age group who suffer from fragility fractures. Has the budget allocated more funds towards osteoporosis?
Has the government allocated more funds, did you say? That's a very good question.
We could take that on notice.
I could take that on notice. I'm not sure that there was anything for osteoporosis in this budget. I'm just looking at, I've got the lovely Brady to my left who knows all things about these things. Okay, so there's implementation funding, I understand, that was budgeted for by the previous government that is continuing. Look, I'd be really happy to hear about osteoporosis. I know it's an issue for menopausal women.
Yep.
And something that I'm very, very interested in addressing. So I'm sorry that I'm not quite sure I have an exact answer for you, but I'll come back to you.
And certainly for the clinicians out there, the health pathways, which is a sort of assistance tool in clinical thinking, which I can introduce you to at another stage, Ged.
Okay.
Really valuable on site. So I've got a question by a community member, Carolyn Vett, who's I think really asking about that issue about how, you know, how the social determinants of health actually impact on our health and well-being.
Oh.
She's talking about affordable healthcare is really important, particularly as there's a lot of women without sufficient superannuation. And I'm concerned about the quality of life most women will have as they get older. How's the government looking to address that problem? So I think it's that issue about the pay gap, the superannuation, that accessibility and equity as we get older that often, you know, affects women more.
Totally. Oh my goodness. I wish I had a whole hour, Ines, to talk about this particular issue. It's massive. I mean, the social determinants of health impacts on women are enormous. So where to start? You raise retirement, superannuation. The Labor Party, Jenny McAllister, did a wonderful report saying that a husband is not a retirement plan, which I think is very true. And we absolutely need to look at things like gaps in women's working lives where they don't get super during periods of pregnancy, and maternity leave in particular. In later life, where, like with menopause, there's more and more data showing that women leave work early because of menopausal symptoms. They simply, it actually causes them to quit their jobs. There's domestic violence, where we know that you know, if women take so much leave and they have to deal with a domestic violence situation, they end up leaving their work. Very proud of the fact that we just implemented paid family and domestic violence leave, which is wonderful to address that issue. We're looking at superannuation on maternity leave, of course, and also the whole massive issue of homelessness. Women over 55, single women over 55 are quickly becoming overrepresented in our homeless population. So massive billions of dollars being spent on affordable housing, and particularly for women fleeing domestic violence and for older women. In fact, just for your information, I'm having a forum in my electorate very soon on how we can better support single older women who may not be financially independent. So I've got the wonderful Donna Ward, who wrote a wonderful book about being an older single woman, and Katie Gallagher, the Minister for Women, will be coming to Cooper to talk about this very issue. Access to healthcare for improving women's health, which we've talked this whole session about, is a passion of mine, and we are really going to be focusing on that. So look, I really don't know how I can give it justice in a 5-minute answer, but you've hit a nerve with me that is absolutely something that we are going to deep dive into, and securing women's financial and their life right across the spectrum of their lifespan is integral to them being healthy and well. You can't be healthy if you don't have a home.
Financial security, or your equity in power and standing in a community is pivotal.
Absolutely,
really.
Yeah, it's a big question.
It is a really big question, and it's lovely seeing it actually addressed at so many areas. You know, the parental leave aspects, the issues about violence, the issue about appropriate education, flexibility as you move forward. They're all parts of it, aren't they?
Absolutely.
Now, apparently I need to wrap up at the moment. So my issue is that multiple people in the chat have said that your comment about women not being believed in the healthcare system resonates really strongly with them.
Oh, absolutely.
This is something we all know from the work we do, but we also know it in our personal lives as women. And as you've said before, you know, you've been a woman for a long time, and you've heard that not just in healthcare environments, but, you know, in other environments as well. And, you know, it's a really good conversation for us to be able to reflect on what we can do to help women in the future generations really not to have this problem. And I think we need to address it at so many levels of our society. I think we probably have time for one other question.
Can I just make one little comment on that, Ines? Just what you just said, which, yes, everybody, I thank you for. But there are lots of intersectionalities with migrant and refugee women who express pain in many different ways, and you know, from stoic right through to being very vocal, and often because of that variety of way that different women express, particularly with that intersectionality, makes it even more difficult and more important. And I'm not sure I've mentioned that I am establishing, and this is an announcement tonight a little bit, because I haven't done this publicly yet. I'll have to shoot you all out once I tell you, but I am going to establish a Women's Advisory Council, which will look at all of these issues that have been raised tonight, and will its sole purpose will be to help me work through the gaps and the differences between the sexes in healthcare, and advise me and Minister Butler on the best ways forward to make women's healthcare better. Now, we'll be making that announcement in a couple of weeks. Just got a few little finishing touches to do, like who's going to be on it. And once we get there, I think it's going to be so exciting to actually really highlight all of these at a high policy level.
That's right.
Really looking forward to that.
I mean, you need to put that shining that light on an area.
Absolutely.
Actually, so you can have that deep dive, but also go across. And we know, you affect a woman's health, and you actually improve the health of children moving forward. You improve the health of their community. It pays off in dividends.
The rising of the women is the rising of us all.
So look, I can't thank you enough for taking this hour out of your incredibly busy schedule to actually talk about things that are incredibly wide-ranging. We talked about parental leave, we talked about osteoporosis, we talked about Roe versus Wade, and you gave us an insight into how you and your government actually view these things, and that how you're moving forward with them. So thank you so much for joining us this evening, and thank you to everyone for joining us this evening as well. I'd invite you to email us with further questions or comments on info@nwmphn.org.au, and we'll attempt to get those questions and comments to relevant people to consider. So wishing you all a lovely evening. Thank you to the teams at North Western Melbourne Primary Health Network for putting this event on tonight, and thank you, Assistant Minister Ged Kearney, to you and your team as well. Thank you.
My very great pleasure. Good night, everybody. Thank you.